All right, first of all, we need a round of applause for our hosts and scribes who volunteered. We had one training session of 15 minutes to get ready for this. So great job, everybody.
Lori, thank you again.
Great, and if everybody can go on mute for just a second. We're gonna prepare for a very, very brief report out. So as you can see, 149 participants, 19 breakout groups, thousands of ideas, and variability in how those ideas were captured. So that's great, a lot of diversity there. So what I'm going to do is we're gonna go domain by domain, and I'd like the hosts to share with each other anything that was surprising or anything that was notable in your various rooms. We don't need the story of your discussion or any dramatic moments, just some raw output. But what moved the needle? What was something that really stood out for you? We're gonna begin with the only domain that had solo player, and that is reimbursement. So
okay.
Yep.
So as anticipated, we did not really have enough space in these tiny little squares to express all the frustration that everybody feels in regards to all of these aspects. So I would say that was the predominant theme, is the frustration with the inconsistency, the lack of utility, the waste of time, pretty much across all of them. And there's lots of different ways we potentially could address it, though ultimately, and again, we left for next week to discuss which one we think we're going to lean toward. I have my own personal biases, which I'll stay away from for the moment.
Great. Anything positive that came out?
From these three? No, there's nothing positive to say.
All right.
I mean, okay. I'll let someone else from the group, if someone from the group felt there was something positive, feel free to speak up, but I heard nothing positive.
Positive right, that so we're all in agreement.
Lots of opportunity there.
There you go. The positive was we were all in agreement that it's terrible.
Yeah, nice. All right, let's hear from regulatory. We had Yigar, Cheethan, and Trent.
All right, this is Trent. I'm going to jump right in. We had 2C accreditation organizations from the ambulatory environment. We had a great discussion, which I'm not going to tell you all about. We came up with 5 general guiding principles, summary thoughts for day one. Those are outlined in big on the post-it, but basically there are too many different standards that are not synchronized among each other and with federal state standards. The accreditation organizations are trying to solve important problems like quality, but there's no clear environmental scan indicating the impact of solving one problem on other things like burden. There are a whole number of solutions that we'll dig deep into next week. All of this takes place in an already overburdened ecosystem, and there should be a drive towards more evidence base in regulation.
All right, let's hear from our other 2 hosts. Anything surprising?
Yeah, this is Jigar Patel.
Hop in.
Yeah, Jigar Patel with the 2A inpatient group. I think when we look at the state and federal inpatient venues, it has wide-reaching implications that cross into many areas that have already been discussed, from payment and fraud to elements around quality of care. In the end, it's a multifaceted problem and needs a multifaceted solution that is contextual, but then also not burdensome, obviously. And the current, I think part of the takeaway on the FAST is current technology is not there, as we all have talked about previously. And in the end, what I've always thought about this particular thing is separating the actual regulation from, say, reimbursement, which they're tied together, from the accreditation organizations, which were just touched as well. And then commonality of terms, et cetera, is important from how do we get to a solution perspective.
Right, and unfortunately we need to move on. So we're moving on to quality. And once again, just the highlights. What are some things that are new in quality or common across all three of these areas?
So hi, this is Kenrick Cato. I'll jump in. We talked about state and federal quality reporting in the inpatient setting, and I think something that's a commonality that I see emerging is just standardization. We spoke about having, the need from both a reporting standpoint from vendor side and also from the inpatient side, just having just one quality standard for, so that there aren't these overlapping different bodies that are asking for slightly different things. And then also another thing that, we talked a lot about incorporating the patient into reporting, which is something that I think is new that hasn't been mentioned, and leveraging the patient's ability to, for example, provide outcome reporting because the patient, lives the outcome. And so I think that's something that we can think about. And then finally, there was a small mention of blowing up the EHR and starting from scratch. And we can talk more about that in the future.
Hence the bomb icon.
Nice.
Yes. Right. Understatement of the day, the patient lives the outcome.
Yeah.
All right. Very quickly,
Okay.
thing to add, Paul and
Yeah,
Bonnie.
sure. 3B, we started with the problem to solve. So our topic was quality measures from the regulatory and government agencies point of view, and we included payers and accreditors as part of that organization. Our problem to solve is really to compare the value proposition to the level of effort. Unfortunately, after we enumerated a number of value propositions that benefit the individual population or knowledge discovery, we concluded that the quality measures we're being asked to create didn't meet up to those. So really, there's almost that numerator is very, very low. The level of effort, on the other hand, is very, very high. The obvious one to the clinician, but also the hidden ones to the administration that's behind creating reporting and gathering all this data for the quality measures, and the hidden cost of the time away from patients. So really, we are producing very little value with lots of effort. And we ask ourselves, is there no disincentive for worsening the situation? And we might have uncovered that what's the incentive? There is a potential beneficiary. Those are the payers who don't want the claims. So there might be some perverse incentives going on here. Anyway, so we weren't too hopeful about what exists, and we look forward to creating a new world next week.
Thank you. All right. Unfortunately, we got to move on to usability. All right. Here's the challenge for usability. You can't mention any pain points, only optimism. So there were 4 different groups. So you have 2 minutes to talk amongst yourselves.
All right.
What are you really excited about?
So so we were 4A, usability on human factors. I think we were saying, it would be great to create contextualized views to help for documentation. And I think that was one of the kind of general theme is how do we do documentation at the semantic level. One interesting suggestion that Dan had, besides his metaphor of using children's toys to look at UI factors, was adding different workforce for certain tasks like the regulatory or administrative tasks, so that reducing that burden to focus only on clinical purposes. When we switch to the question on
sorry, Karthik, there are 4 other or 5 other hosts. So tag somebody else. You have Kevin, you have Susan, Julia. Somebody else jump in.
Okay, here's Kevin. I'll just go. Simplifying what we already have and using modalities that are more in line with what patients are expecting during the visit was the central theme of where we'd like to see things go.
Right. I'm happy to jump in next on the training piece. I think our conversation was very much about the training model feeling sort of broken, this notion of you sit in a classroom and then that's followed by some, pulling people out of clinic to, try to teach them other things and then have them go back. And so I think our big, bold idea is that really training should be an ongoing process where there's sort of smart agents or real-time feedback where you can actually observe and understand what the user is struggling with and then be able to sort of train them in practice. And so that's a model is that, we should adapt towards, and it sort of moves away from this notion of training as a separate activity.
Wonderful. Judy Ross?
Yeah. Judy from Workflow. Basically, we were thinking a lot about the workflow of actually documenting real time as compared to the workflow that's required for data retrieval and data synthesis and telling the patient's story, and the dichotomy that we're feeling between those different activities.
Thanks. We have to move on to interoperability. I'm glad that Dr. Cahoney is not here, or else he said he would fall asleep. So bring us to life. What's exciting in interoperability?
So I think that the struggles that we mentioned were really bringing together all of the various data streams and then struggling to really separate out the difference between what are the rules that are necessary to facilitate that versus what are the standards that are necessary to facilitate that versus what are the protocols that are needed. And I think that the primary focus was the fact that, we really shouldn't have to reinvent the wheel in every organization to make certain that that was done. And I think that the other important factor on our second question was really about the fact that, audit trails are not the same and are not easily exchangeable between systems. And that's something to think about if we use that as a tool moving forward to try to streamline documentation.
Andy, what's exciting from your group?
We had so much that was exciting, including the joy of the interface you provided for us. Notice we are not a sticky note kind of group. So we had demographics need to be more sufficiently defined. Example was addresses, and maybe the U.S. Postal Service will do more about that next week. Some concerns about HIPAA as an obstacle. And some absent expectations for standard sharing, which is images and actual image sharing, not the report of images, would provide substantial improvement. We also talked a little bit about, do the standards as they exist, are they sufficient? Are the HL7 standards sufficiently defined so that we can share information across different platforms and across different institutions? And then there was some really intriguing discussion about, on the federal side, whether or not we should take more advantage of NIST to help further specify. And we all kind of threw up our hands relative to how do we communicate what the standards and regulations are, aside from being focused on the Federal Register constantly.
Cool. Thank you, Andy. All right, the four hosts from Self-Imposed. Once again, what are the highlights? What are the big ideas? You have 2 minutes. Talk amongst yourselves. Please share the floor.
This is Sherry. I'll start. We had Self-Imposed inpatient, and one observation is we didn't have a physician in our group, so it was mostly nurses and one respiratory therapist. But really, culture isn't just internal, but also external, what we see, and a lot of conversation and ideas that really move towards interdisciplinary teams working more closely together and understanding your scope of practice.
Thank you, Sherry. Jeff, Patricia, Vicki?
Sure. Well, we had we had organizational culture, ambulatory, and we felt we were surprised by the number of things we could come up with. That our training leads us to over document, and there are some things we could do hopefully within the system to reward not under documenters but appropriate level documenters, and maybe even cleaning up our notes so that they aren't full of anything that had to do with regulatory stuff that ought to just be pushed aside and not ever be something that I would have to look at again. And there were so many good ideas. I'd hate to just you know, you've got stuff to look at.
So hey, it's Patty Singstack, 6C, self-imposed pressure from compliance, risk, and legal department. So the mantra, if it's not
big idea, 6 seconds, go.
Oh, okay. We need more data. We don't know how often there is a problem. We need more collaborative teams to work together to solve problems that aren't necessarily technology related or need the documentation.
Wonderful. Last word, big idea from the final group.
Yep. So we thought it was very difficult to discuss the compliance and legal and risk because it's so heavily intertwined with external regulatory and billing. And we brainstormed on some changes for tort reform and professionals and liability cases and some soft barriers within organizations.
Woo. Thank you all. 6 domains, 19 groups, 149 participants. Really appreciate you very much. I'm going to turn things over to Trent and Sarah to close us out.
Wow, what a day. Thank you all so very much. Don is clapping. I share the clapping. Thank you, Peter and Holly, for your facilitation. And again, thank you, Zach, though I don't think you're here, for your remarks at the start. Just a couple quick points. First of all, please come back next week and help us finish this work. Number 2, there's a couple comments, and this reflects stuff we said at the beginning as well. Not everyone could get everything down in the Mural software. Don't worry about that. If you feel you must, send me an email, send Sarah an email with your thoughts that you couldn't get down, or just write it down on your favorite word processor or notepad and bring it back to your own breakout group next week. Don't worry about not quite getting it into Mural the way you want to. That's a tool. It's not a definitive solution. Jeff Williamson, are you on? Jeff Williamson.
I'm on.
Great. We had some questions in the chat about folks getting on the listserv. Is that up and live?
It is. Just send me an email, jeff@amia.org.
Can you put that in the chat, please? Thank you.
To clarify for everyone, that will be via the AMIA Connect platform, and it will be available to anyone part of the symposium, even if you're not an AMIA member.
Great. And you can also access that via the Symposium website. So a lot of great work. We've been efficient today, and that's really all I have to say. Sarah, do you have anything further to say?
I just want to say I was thrilled with everyone's participation. You know, this was really fabulous. I know in our breakout group, you know, we had some really great ideas. And thank you to our facilitators and our scribes who, you know, were willing to put in some extra time for their training. And we look forward to more breakout groups next week.
Great, thank you. So again, if you think of anything that you didn't get into your breakout group, just jot it down, send it to us, hold it for your breakout group next week, and please, please, please come back. We're almost there. Thank you so much.